I said thanks very much for both of these excellent presentations. And we'll now, as before, entertain questions from the roundtable members. Again, if you'd put up your cards and introduce yourself. And I think we should be able to get to the audience this time since we have until 12:15. Steve?
Hi, thanks. Great presentations from a clinical standpoint and from the consumer standpoint. And I do agree, Andrea, that e-health literacy or electronic health literacy is really important, since a number of the ways we're doing things is asking people to go out online and do things. So I applaud that. Lynn, your presentation was tremendous, and I do appreciate it. You also did some research on health insurance literacy, and I'm wondering if you could just say a few things on that as it relates to what you talked about this morning.
No, thanks very much. So it was actually at an IOM workshop, I think 2010 or 11. Can you remember? Yeah, 2011. I was presenting much of this same research. I don't think we had the video then. And one of the things I said we really need to do is we need a better way of measuring health insurance literacy. I know we have fabulous measures and widespread use of health literacy. But when I look at those measures, when I look at the components and what you're being asked, we really aren't getting at all these problems with shopping for health insurance. We aren't targeting what's hard about shopping for health insurance. And understanding how to shop for and use health insurance is a component of functioning in the health marketplace. So I sent out a challenge to IOM that we really need a way to measure this, because when you measure something, then research is conducted and you make forward progress. And someone in the audience from University of Maryland said, oh, we should definitely do this. And I'll make a long story short. The American Institutes for Research, AIR, is working on a measure of health insurance literacy. It's been through several rounds of development. It is not complete, but that will, I think, facilitate this research. I don't think they have a way of breaking out the numeracy. So there's more stages to come in the future. I would have loved something with this sophisticated scoring system whereby you could say what which component of the score is related to numeracy versus other things. We're not quite there yet, but that's something that is going on that Steve is part of. Do you want me to say anything else about it?
No, I think that just that this is going on, and it's similar to using a NALS approach. But I think a lot of what was done was also going back to the uniform glossary, and that came out through the Department of Health and Human Services, the Department of Labor, which was part of how do you provide, break down the complexity of those terms like copay and deductible and coinsurance. And the Consumers Union did a really great usability test on the terms that came out from the National Association of Insurance Commissioners, and then ultimately moved into the Uniform Glossary.
Actually, I'll say one word about the glossary, which will probably make sense to most people here. So this is in connection with developing that summary of benefits and coverage, the standardized way of explaining a health insurance policy. There was also an accompanying glossary. And the glossary is great in that it is written in fairly plain language. There's a couple actual visual examples. However, what our testing showed is, because it's kind of this standalone product and it's not context sensitive, most people said they probably wouldn't go and find the glossary if they were having trouble understanding something in an insurance policy or in the summary benefits and coverage. So I think it's great that the glossary exists and that work was done on it, but I just want to say, like, our work is not yet done, in that we can't assume that consumers will go and seek out that information in order to help them with their shopping experience. So if we can get even more context sensitive, so it's right there in the policy as opposed to in a separate document, we'd be even further along.
Thank you. I just wanted to make a cautionary note about too much emphasis on measuring the skills, i.e. the deficits of people, which is in a sense we already know from the national assessment tools. And I'm going to offer a quote from a colleague who's here in the audience, Susan Reed, a lawyer, literacy expert, and an advocate for health literacy, who grew up on a farm in New Zealand. And her statement was, we can measure a cow over and over again, but we're not going to grow a cow by measuring it. We have to feed it. So I really love the emphasis that's being placed on actionable items, what we can do to really make a difference. And both of you, with pre-testing and pilot testing and really getting the consumer voice, with giving advice to the clinician about how to reframe, how to do things, I think that's where real efficacious action will come. And I'm so pleased about that. And thank you both for that.
A question and a comment, so I'll just start with a question. This is for Lynn, I guess. I think one of the big confusions, and you touched upon it, but I want to know what you think more about it, is the difference between costs for in-network, out-of-network, and then if you have multiple tiers of network, and which are often different for different kinds of services. So what have you learned about that issue?
So the testing that I referred to earlier didn't do too deep a dive in that, just to make it clear where my answer is going to be
Right.
coming from. But based on what did come out of that research, as well as the research of others, this is something that advocates hear about all the time. It's an absolutely tremendous source of confusion. In fact, when Terry was saying that she went out of network, people who understand what that means, there was a little bit of a, it's like, are you bankrupt now? I mean, it's.
The answer is yes.
This is an area where quite a bit of work needs to be done, and it's across several dimensions. There's many things that are confusing about out-of-network. Just simply, what does it mean to be in versus out is a point of confusion. Then there's what does it mean financially? So people actually can quickly understand, well, it's probably more expensive if you go out of network. Well, how much more expensive? And they're stuck. We don't know. And one of the things that's in the Affordable Care Act, kind of in the still to come category, is to improve measures of network adequacy. And I think a lot of people are thinking that that is going to be, well, we'll just kind of take the best of time, distance measures, and geography measures and what's going on now. But although this will be this year's challenge to the IOM, we'll see what happens in 2 more years. I think we could take this much, much further and develop sophisticated measures of health plan network adequacy that don't exist right now, that not only tell you, how broad or narrow is the network of physicians you have access to, but how financially accessible is that network of physicians that you have access to, and how and do these people have space in their patient, can they accept new patients? Those are all dimensions of the network that consumers really need to know. And particularly that financial side, if we could, nobody has ever tried to do this, but I don't know why it couldn't be done. And that's something I think that could really help consumers.
My comment is for everybody, but for Andrea, related to Andrea's talk. I think, and this is related to Ellen's talk earlier, I think sometimes what we've discovered, we've been trying to design a better asthma action plan. You saw Andrea's example, which is, I find, totally confusing for parents and often who don't speak English and are at relatively low literacy. And we've made the decision to leave off peak flow for a variety of reasons. One is exactly, it's too complicated for actually to help parents figure out when to go from green to yellow to red. And in pediatrics especially, it's very hard to get the kids to give them an accurate peak flow. So that gets to the issue of sometimes you need to just decrease the load, even if by the way, I was one of the people who fought that the most in my group, and I said, no, we have to do peak flow. And eventually, of course, I was won over that. In fact, I may want to believe that people use it, but they don't.
I actually don't use it very much. I put it up there as an example of what's difficult. What could be simpler would be to take off. Maybe the patient only needs a section of that red light section. Maybe another patient only needs a green light section. And only occasionally, I think it's burdensome to ask patients to use peak flow meter. And it was just an example. I didn't mean to stick to asthma that much.
The criticism of your talk was just using that form as an example of
I
how
quite
difficult it
agree.
is.
Thank you, Pat McGarry, AAFP. This isn't really in your world, but you may be familiar with the American Heart Association's Know Your Numbers campaign, where they ask people to keep track of their blood sugar, blood pressure, blood cholesterol, and body weight. And they even have handy little guides to keep track of your numbers. Are you aware of any research that looks at the self-efficacy or the locus of control and knowing your numbers and if it really is efficacious?
I don't know. There's so much we don't know. We need research to know that sort of thing. And it's very simple, important information.
I'll just say, I think it's a great question because a lot of times I think we feel that, oh, I've probably created a great piece of consumer information, but we don't know until we've tested it. So I think it's a great question.
Hi, I'm Linda Harris. I'm with HHS, and I want to thank you all for your really excellent presentations. My question is to you, Lynn. As you probably know, the administration's key target for ensuring people for the next round for the marketplaces is young, healthy men. My question is, do you have any information in any of your research that will help us understand more about how health literacy or numeracy may be a challenge, a particular challenge for this group?
No, I don't think that the research I did really sheds light on that, but we have looked, we have a similar goal. We'd really like to see people take advantage of this act and gain insurance. And so I've looked extensively at the research of others, and I think for these healthy young men, it's really a motivational issue. It is, for example, we know messages like, forget having better health, that will not motivate them. But if you say, if you're uninsured, you might lose your truck, they're motivated. So I think that's the key with that particular group is these motivational type of messages as opposed to overcoming numeracy barriers. But that's just one little piece of the puzzle.
Well, first of all, Lynn, I can tell you losing his truck would motivate my son. And thank you for your work as always. Andrea, I wanted to ask you a question. I really love your matrix for simplifying information. And this is my broken record question. Do you have any experience using it with trainees, either medical students, pharmacy students, nursing students? And if you do, how has it been received?
Oh, what a great question. In talking with residents and medical students, I might talk about the concepts. I haven't actually said, I made this matrix and look at it. I admit I haven't done that, but I use the concepts in talking with them.
How do they receive it?
Well, they're respectful. They're not.
That's better than the alternative, I guess.
May I just respond just very briefly? I use it all the time with public health students, many of whom are MPH students, and they love it because it's a little tool and they can do something with it. They can use their hand and see how to move in one direction and move in the other direction up. So the reception has been very positive. Now, do people out of school apply it to their real life? I don't have a follow-up study, so there's no scholarship involved in that, but it's a lovely tool to articulate and discuss with people.
Thank you.
Oh, that's a nice segue. I'm Cindy Brock from the Agency for Healthcare Research and Quality, and I wanted to pick up one piece of some of the many different ideas that have been floated around about kind of ways in which we can try and close the gap between the demand, to close the gap between the abilities and the demands. And that little piece is removing non-essential information. And Ellen, in her paper talked about providing less information, moving along your grid. You need to sort of operationalize, well, what would that actually entail? And this is something that I've struggled a lot with recently. Mike Wolf and Sarah Shoemaker and I have just finished developing something called the patient education, patient education materials assessment tool. The idea that we have a tool to be able to rate materials as to whether or not they're understandable and actionable. And how do you go about deciding this material has something that's, non-essential? And an example from Lynn's piece was, if you had given me the summary statements and said, oh, I'm putting that it costs $98,000 to treat breast cancer, I would have said, well, but that's not essential. What's essential is what they have to pay, and that's what they want to know. We should cut this out. So are there any strategies to help people who are trying to actually implement these kinds of advice to reduce quantitative cognitive load, to make those decisions? You said, well, it makes a big difference between saying 30% live or 70% die. Well, how do you decide which one of those is actually the right way to frame that? Is there anything that helps provide guidance as we're struggling to put this into action?
I don't know about if there's any formal guidance, but I think nothing replaces the conversation between the patient and the clinician, to try to understand what makes sense to them and what their priorities are. And that's what when I was bringing up the electronic health record, there are places now, for example, in the after visit summary, where it's printed out for the patient, their vital signs and their medications and where they went, but also a place for individualizing and tailoring information to the patient. And that may be the most critical part, to give the very essential information in the way most pertinent to the patient. And then as we get more facile with the patient portal, that will be another way to individualize and tailor information, but that will require education not only of the patients, but access for the patients and education of the clinicians too, and reformatting the whole thing.
And on the health insurance side, I think this is a great point. And I think the reason that showing all three pieces of information, what the medical treatment cost overall, what the plan paid and what the patient paid, is that patients need that framing. It's framing the bottom line for them. And that was really missing in their health insurance shopping experience. And so I don't have a overarching strategy except to just put my broken record back on and say we should just take our best guess, do well-designed consumer testing, and let them tell us what is essential and what's not essential information.
Hi there. I'll try to move this closer. My name is Lindsay Robinson, and I am new to the roundtable. I'm a dentist, pediatric dentist. Very happy to be here. And also, I'm this year president of the California Dental Association. And thank you both for your really interesting presentations. This whole day has been an eye-opening experience for me. And first of all, Andrea, I wanted to ask you a question in terms of oral health. The impact of the asthma medications on oral health, and I didn't see it listed on your asthma action plan. Where do you provide information to parents of children who are newly diagnosed about the potential impact to the dentition of the medications? And I'm just wondering is it anywhere in if you verbally provide that, or if there's any written information that goes along with all the information about treating asthma, if there's any information within that material.
So that's a whole gap in medical education and medical treatment in general, that dental health is not considered the way it should be, that if you don't have adequate dental health, your whole life can be impacted in your nutrition, your ability to obtain work, your appearance, your ability to eat properly. I have to say that in medical circles, it's not covered, and it's not even mentioned in asthma treatment.
That's unfortunate because I'm a pediatric dentist, and I've treated a couple of kids with massive, just rampant decay. And I think part of the issue was the fact that they were on asthma meds, and that the family members who were the caregivers for this particular child never got the information about the potential for the residue to destroy the teeth. I think that, and then that you're dealing with a child with significant asthma, and often those children have to be hospitalized to provide that kind of surgical intervention on the dental side of
So
things.
I actually see adults more than children, but there's nothing in the literature which means to me that the first thing is we really need to do some research on these risks.
Yeah.
And it would be important. Yes. Just anecdotally, that's something that comes up.
Okay.
So it really needs an area to be explored.
Yeah, it sounds like it. Yeah, and then Lynn, I had a question for you in terms of your research with consumer groups and their understanding of health insurance. Have you ever done anything around dental insurance? Because that's part of the essential benefit package is the pediatric oral health benefit, and a lot of families who've never had dental insurance will be obtaining it for the first time, and it's confusing for me, and trying to deal with the insurance companies and my office staff to help our families understand their benefits. So I'm just curious if you've done any work around that.
Again, not personally, but I'm pretty familiar with the research. People really want dental coverage. That's actually a motivating thing, even for our young, healthy men. That if there's a dental benefit included in a policy, they find that very attractive. Unfortunately, I feel like this is one area where the Affordable Care Act, the way it's being implemented, has actually made it pretty confusing because of the dental policies can be offered on a standalone basis. Does your tax credit, I think we shouldn't get into it here, but there are a lot of questions about if you're eligible for a tax credit, does this apply to your dental policy? Do you have to buy it? Are you in compliance with the individual mandate if you buy it? Because it is not wrapped up into the medical benefit, it is actually I'm anticipating it's an area of confusion for consumers. So I'm hoping maybe there'll be a forum where we can talk through how to help them with that.
Thank you. I really enjoyed your presentations. I'm Margaret Levin from Merck. I have one quick comment and then another question. The comment was about the Asthma Action Plan, and we also developed a low literacy one, which I'd love to share with you and get your opinion on, with peak flow and without peak flow. And the other comment was, I was looking at your summary slide, and it is essential to equalize and enhance educational opportunities. And I was kind of wondering what you meant by that, Andrea. Is it at the child level, the consumer level, the physician level? And did you have any specific things in mind there? Because that obviously is the solution to the whole problem. Yeah.
Well, first of all, I think that our schools, our public schools need adequate support and resources, and that they have to be equalized throughout the country and throughout, there shouldn't be communities where there are resource poor schools and communities where there's resource rich schools. I think we have to, I used to be a math teacher, so I guess I can say that. I think that we have to teach the appropriate skills. We talked about earlier that there's a difference, Dr. Ginsburg did, between math in the school and the numeracy, the skills that people need to live their lives, and we have to constantly think of those and determine what they should be. Because in all the research, at least that I do, health disparities go back to income and education, and societies being deprived of the adequacy of education influences how much income they can make, how much health care they can get, their jobs. So,
Right down to
that's-
the public school level.
Right, so I
Yeah.
think it's important.
This has been a really great morning, and thank you guys for your presentations. I guess I have a comment with a question attached. Two comments. One comment, just in seeing, Lynn, your excellent video, and then hearing you talk, it really struck me when you went into your description of how do we explain in-network coverage versus out-of-network coverage. And I thought, how long are we going to chase our tails with every little permutation that the insurance companies develop to corner the market, or, you know, to establish quote unquote efficiency, which of course is using up endless resources of each person in the population and each healthcare system because of the level of complexity. And you're doing yeoman's work to try and bring this to the level of the consumer, but it's, what's the next thing that's going to come? It seems like every time we get clarity on one part, say deductibles, there's another facet that we need to learn. And maybe well, Susan stepped out. America's health insurance plans. I don't know what's going to fix that problem, but it's very frustrating, and it's hard to watch us continue to chase our tails. I wanted to follow up on, I think, Cindy, you raised really excellent questions about what do you present and how much information is there. And I thought you gave a very powerful illustration of the value of saying it costs $98,000 for the insurance company and $2,000 for you. And I had a similar reaction that Cindy did. And I thought through my own experience as a clinician that I sort of separate information into what people need to remember versus what they need to be receptive to what they need to remember. And no one in your video needs to remember that it costs $98,000 to treat breast cancer, although they all will, because it's so astounding. But they need to remember that $2,000 as they make a decision and compare to other plans. And I think we're often left with, you know, how much do we need to teach them about their asthma versus what is the need to know and need to do? Do they need to know the difference between a controller and a rescue medication? Most of us think yes. All at the end of the day, maybe all they need to know is that when you cough, take this one and make sure you take this other one every day. And for some people, that might be sufficient. So how do we, you know, figure that out? And I think, Lynn, what you showed us is talking to people and seeing their reactions is one way to figure that out.
Hopefully, I have something hopefully encouraging to say. So when the new exchanges open around the country, there's like 18 or so state-based ones and 30 or so federal ones. So there's going to be a lot of differences in how health insurance information is displayed that we can exploit from a research perspective. And we have Massachusetts and California and a few other states are going somewhere down the continuum of trying to standardize these health insurance products even more. And so there's a scenario possible under which people will say, oh, that really worked well. And, you know, it will become more common that things are greatly standardized so that consumers can have the cognitive bandwidth to actually compare these complex products. And coming back to that coverage example and how much information is important, I do want to underscore that it was not only did showing that bottom line of I pay $2,000 help consumers rank order plans, which is an outcome we want, but don't forget showing the other information, how much the plan paid, motivated them to buy insurance. So there's a couple things going on there, and I'm going to stick to my guns and say we need all three pieces.
I think with the talk about numeracy and simplifying medication and simplifying advice, it's important to realize that not everybody needs a simple explanation. The important thing is to gear it to what the patient needs for their information. But I do think people do need to know the difference between a controller, I'm not sure I like that word, and acute reliever, because that tells them how to use the medications properly.
I think that I don't see any tense up. Oh, I'm sorry, Wilma. Yeah.
Wilma Alvarado Little, Center for the Elimination of Minority Health Disparities, UAlbany SUNY. And my question is, I was thinking about it as Darren was talking about, you know, the out of network, in network, and then how is somebody going to be trying to calculate the expense, if you will. So has there been a discussion with providers on how to perhaps help the patient navigate that? So for example, I've had experience where a provider has referred me to provider X. And so wherever I fall on the axis of being obsessive compulsive, I want to make sure that that provider is part of my network. So then I find out that provider's fabulous, but he's out of my network. So now I have to make a decision, but that's me. So my question is, has there been a discussion on, for example, the provider being able to maybe add a comment like, we would like to refer you to X, but you might want to check if they're within your network. Because I think, you know, you can't remember who's everyone who is in every plan, but how can that connection be made from the provider to the patient when they have to be in a situation where they might have to start doing some math to figure out options?
I'm not aware of any research that tests that, but I could certainly see typically when you get a referral, you know, they'll write it down on a piece of paper, and the piece of paper could say pre-printed, you know, make sure this call to see if this provider is in your insurance network first or something. I think it's a good idea. I think there is some evidence that providers don't want to get too deep in the role of helping you with your health insurance. They really would rather somebody else do that.
Yeah, hi, Kim Parson from Humana, and I would echo what Lynn is saying, is that I don't think providers see that as their role. One of the things that we've done is to proactively notify our members. So if a referral request comes through that you need to go see a cardiologist, and we note that you're going to someone who is not in your network, we'll do a proactive outreach to say, you know, this person is not in your network. Do you know that? Are you interested in other options of cardiologists who are in your network? And then the member makes the decision on whether or not, you know, they go in network or out of network, and have an opportunity to understand the difference in the cost for them.
But what we have found through some of the work that we've done, and it's not anything that we could report as far as research, but working with communities, is that when they're standing in front of their provider, that's who they're trusting. You know, and I completely understand, you know, the other side of what you said, but you know, it's a concern that we see in more rural than urban areas. And so I understand that, you know, the provider barely has enough computer time to see you for the amount of time that they're scheduled to see you, let alone take, you know, other things on. But I was just wondering about that.
Yeah, certainly we understand that as a payer that, you know, we don't have the same sort of permission space that a provider would have for that. But we do feel it is, you know, our place to educate that consumer so that they can make a better educated decision.
I'd just like to underscore that, coming back to what Rima said about getting to actionable things. If you design a consumer communication, your work is only partly done. Whether or not that communication is coming from a trusted source is very, very important. Consumers won't act. Humana could be providing the exact same information, but the consumer probably won't act on it because Humana is not a trusted source and the doctor is. So it is something we have to keep in mind in terms of basically, you know, having an impact at the end of the day.
So I will just add that we see in our data actually that over 75% of people that receive those calls saying, no, actually, I didn't realize that that person wasn't in my network, and thank you because I do want to change.
Yeah, and I didn't mean to say that you shouldn't do it. It's just, there's just a lot of evidence that we do need to look at that source. So yeah, no, keep doing.
Thanks for the great presentations, and in fact, all morning. And I keep coming back to patient-centered medical home and the idea of a team approach to care. And I'm curious for the panelists, when you think about what providers need to accomplish in their day, which is about 17 hours worth of work in an 8-hour day to see patients and do the prevention, and that doesn't include teach back. And that doesn't include knowing who's in and out of a network. And so I'm just curious, as for the physicians up there and in the room, how you see, I'm a nurse by training, and I see a lot of the conversations that are much better located with advocates, health coaches, nursing, and just curious how that looks. And then thinking about the trusted source, and we do know that patients probably trust their physician more than just about anybody in that team. So I'm just curious what you guys are thinking about that as you consider how we help patients understand what's available to them.
The team approach and multiple doctors is always a big concern, and I do and our colleagues do the best we can to communicate with each other. Where I work, it's often hard to identify. It's not hard, but there may be no standard team for all the care, and so coordinating the care and doing that and communicating with other physicians and then back to the patient is really key, and something we all try to do as much as possible. I'm not sure that answers your question. Maybe you'd ask me again.
Okay, I think I'm correct in this case that we don't have any new. So let's take 10 minutes to 20 after for questions from the audience. And please feel free for comments or questions on all the presentations this morning. Yes. And if you want to say something, if you would use the microphone, which is at the back of each. Thank you.
Sure, thank you. It's a delight to be here. I'm Heidi Silver-Picola from the Department of Education, the Office of Vocational and Adult Education. So you're talking about our peeps. These are the adults out in the world who need basic skills remediation. And we talk about adult literacy and adult numeracy all the time. So we're delighted that you are also talking about the health and well-being of our people. I wanted to let everyone know that there is a new data source coming out. You've used the NAL very well. Health literacy researchers have probably been our best researchers using the NAL, but there's a new data set that will update all of us on the health and numeracy skills and the digital literacy skills of adults, and it's called PIAAC, P-I-A-A-C. It's actually an OECD study. It's being conducted in 24 countries in this first round, and they're adding another 9 countries. It's nationally representative data. It will not have as many in the sample as the NAL did to get down into subgroups, but there is another round of sample being taken. So it will grow, the sample will grow, and all of this will be released October 8th. The international report and a U.S. country report that adds in the layers that will speak to this educational inequity. We have 50 years of the achievement gap to deal with in this country that has resulted in these inequities in our adult population. So the U.S. country report, we'll try and break that down into race and ethnicity for our country. All of it comes out on October 8th. The data will be public use data, and there will be a lot of data tools that we can all use to get in an easy way. But I'm sure that those of you at universities have grad students who would be interested in a new data set and really want to get in touch with you about data training that will be happening after that's released. So I look forward to coming in a year or two and hearing you talk about, well, this is where we were with the NAL, and here's where we still are, unfortunately, in the PIAAC. But we need that updated data because the NAL is getting kind of outdated. And I just want to say, as an adult ed teacher for many years, that this is health and involvement in your family's health is an awesome opportunity for patients to learn, to become educated, and to grasp new concepts. So I just want to put that out there, that as we think about materials that speak to low literacy, there are also building in opportunities to learn. People aren't stuck at levels of literacy and numeracy. These are opportunities to learn. When you're taking care of asthma with your child, lots of opportunities to learn. And we see people learning about learning literacy and becoming advocates for their families. So that's my own personal piece. But thank you very much for the day.
Could I just ask everyone to be concise? That was wonderful information we need, but if we're going to answer all these questions, we really need to have brief questions and as brief answers.
The follow-up question was, what does PIAC mean? It's the Program for International Adult Assessment Skills and Competencies.
Okay, let's take a question from this side.
John Gardner, retired from National Center for Health Statistics, which is part of the Centers for Disease Control and what's that? Oh yeah, prevention. Yeah. Okay. I see literacy and numeracy things in there about taking medications. What about exercise, diet, lifestyle matters generally? Don't you feel that first of all, physicians need to do a better job of communicating preventative information to patients, and patients need to be educated in the literacy and numeracy related to that? How do you feel about it?
Absolutely. And maybe even system-wide, we need to promote better health.
And I agree completely too. I only used my examples from directly where I'm talking. I didn't mean to say that weight wasn't very important or exercise.
I am Helen Osborne of Health Literacy Consulting. It's terrific. You've gotten me thinking. I don't have the answer. But between all your presentations, when you're talking about concepts, and concepts are so word-based, they're so abstract, they're so difficult, that, and then coupled with what Rima asked us to do to deconstruct activities, we're really focusing on tasks. We're focusing on activities. I wonder if we can reframe this, make it like the Apple Store that Terry talked about, that I love to go to. I don't need to know how my iPhone works. It just needs to work. When we deconstruct these tasks, almost everything you've talked about is problem solving. Making decisions and problem solving. Can we put that first and ideas second, really reframe how we're going to get at this? So I don't have the solution, but I'm getting excited thinking about this. I think there's another way to approach this problem. My 2 cents.
Over here.
Thank you. I'm Bill Elwood from NIH's Office of Behavioral and Social Sciences Research. And I think I've been having a mind meld with the two distinguished gentlewomen across the room, and also reflecting on Rima's lessons learned and challenges for the future. So many of those points of your bullets point to the need for basic research. How indeed are people, what are those cognitive steps that people make toward decisions? How do they learn and increase their numeracy skills as a physician or physician's assistant or whomever is teaching them about dosage and times per day? I think it's inquiry into those questions that can help answer some of those some of these needs for the future, and also work in electronic literacy, because not only does that have obviously a mysteriousness all of its own, but there is a different kind of learning that goes on with one's smartphone. And I think linking health literacy research to many of those basic human processes can go a long way toward answering the questions and improving people's health.
Yes.
Hi, my name is Jessica Anker from Weill Cornell Medical College. I'm one of the afternoon speakers, but I just thought I would
step up to say that a lot of the morning's conversation has been about healthcare costs and the fact that we don't have a good handle on what things actually cost. And I wanted to draw your attention to a resource that might be useful on this topic. Fairhealth.org is a publicly available online resource that is set up to do exactly this, to allow consumers to look up what the cost of various procedures and things like that is supposed to be. I really was a little disappointed that Gina Colada did not discover this in her front page New York Times article, because it has been around for, it's been up and running for about a year and a half or 2 years now. So I just thought that might be helpful for this audience.
Sure.
So Fair Health is a wonderful resource. What it is you can go in if you know a CPT code or you have the wherewithal to look up a CPT code and find out what a usual and customary charge or the Medicare charge might be in your area, which does put us ahead of the game. But it doesn't answer the question of when you call a hospital and say, how much are you going to charge for a vaginal birth? And they don't answer the question. Like, it's two different questions. It doesn't say what a specific hospital will charge, which is typically what the consumer really wants to know. But it is a good thing to know about. The thing that makes a tool like that difficult for consumers, though, is they don't know how to build what's called an episode. They may know the main CPT code associated with a procedure if they're very lucky, but they may forget that you also need, I don't know, I'm an economist, but, these other things, those little ancillary things. So it's hard. It doesn't get them all the way there.
All right, I think we are now prepared to break for lunch.